Are you ready for us?
Yes, please. And if you all would kindly introduce yourself and tell us about
Absolutely.
Rankin Jordan Pediatric
Yeah.
Bridge Hospital, because that question comes up often.
Thank you. We're really excited to be here today. My name is Amy Zimmerman. I'm a pediatric rehabilitation physician at Rankin Jordan. This is Molly Danley.
Yes, I'm Molly. I'm an occupational therapist at Rankin Jordan.
So Rankin Jordan is a freestanding pediatric hospital here in St. Louis, and we provide care for children in the inpatient and outpatient setting. So our inpatient setting are mainly kids who are medically complex, healthy enough to leave the acute care setting, but need ongoing medical nursing care and multidisciplinary therapies to address all area of the child's function. In the outpatient setting, I see a lot of children with tone management issues. I see a lot of children with cerebral palsy. But in the last 10 years, we've also started seeing more children with bowel incontinence issues. So today I'm going to open by reviewing our clinic, our multidisciplinary approach to these children with bowel incontinence. And then the meat and the potatoes of the talk is really with Molly. She's going to go into more detail about the therapy and the modalities that we use. So for the last 10 years, we've had a functional constipation clinic. So these are children who are normal healthy children who have chronic constipation without an underlying diagnosis. And as our clinic has grown, as we've had success treating that population of children, and as we've started working more closely with the colorectal team and Dr. Shackshire, we've recognized that our clinical approach can be beneficial to children with underlying conditions. So we've opened our clinic up to include children with any number of disorders similar to Hirschsprung's disease. Kids get referred to us through their GI specialist. And an initial clinic evaluation is with myself and our outpatient psychologist, Dr. Claire Carlin, and with a pelvic floor therapy trained occupational therapist or physical therapist, such as Molly. And we will block 2 hours for our initial evaluation. And that gives us plenty of time to ask lots of questions to learn about the child's condition, what struggles the family and the child have had at home with trying to achieve bowel continence, what has worked, what hasn't worked. But we also want to get to know the child in the broader sense. What do they enjoy doing? What are they motivated by? How do they function in multiple environments, at home, at school, in the community, with peers, with family? Because ultimately, we want to come up with a bowel program that is motivating for the child, that's appropriate for the child, but is also doable for the family. The 5 pillars of our program are dietary goals for fiber and fluid, time toileting schedule, pelvic floor therapy, medications, and documentation. And I don't want to go into too much detail about any one of these areas because I could get off on tangents. I could talk all day. But what I want to say is that when we can be creative and come up with a bowel program where a child can meet goals in each of these areas, their chances for bowel continence success greatly improves. If we run into any specific barriers in any one of these areas, it may be that we as a team need to be creative in the way that we approach how we're creating goals for that child and address those things first before we can anticipate that a child can meet goals in all of these areas. So for example, if I have a child who comes to my clinic and has really significant feeding aversion behaviors or really severe picky eating behaviors, it might be that we need to shift as a clinic to address some of those behaviors first before I can put in a whole program into place. So that might look like the family working more closely with an occupational therapist, a speech therapist, and our psychologist to address those behaviors before we can put other goals into place. Another really good example is if a child comes in and has a really significant toileting aversion and will not sit on a toilet. It's really hard to put a toileting program into place when a child won't even go near a bathroom. So how do we address those behaviors first before we can put more goals into place for that child? With that being said, I'm going to pass this over to Molly, let her talk more about the therapy piece, but we should have time for questions at the end.
I'm going to come on this side because I tend to move around when I talk. So just an overview, this is pelvic floor anatomy. So there won't be a test. You don't have to push.
You don't hold it. You just
Just push it. See, I'm already messing it up.
It's rebooting.
Okay, I can take this one.
Yep, you can take that one.
Perfect. So there won't be a test on this. This is just to show you that pelvic floor anatomy is multifaceted and there are a lot of muscles that go into play. So there are 3 layers to the pelvic floor. And everyone has a pelvic floor. And the roles of these muscles, they all kind of lay right below the belly button, and they support all of the internal organs that lay just above that. So they support the internal pelvic organs. They resist changes in pressure. So when you jump, you dive into a pool, your pelvic floor muscles help support that. So that way your inner abdominal pressure remains the same. They also play into stability. So in order to sit up like you guys are doing right now, to stand, your pelvic floor muscles have to provide an amount of support so you can be successful with that. And then relevant to today's lecture, it allows or inhibits the passage of stool, urine, and gas. So like Dr. Amy said, our team will typically see people in clinic, and then the therapy specific piece has a lot of components to it. So the first thing we like to look at is overall a sensory assessment. So does your child have the urge to use the bathroom? Is your child able to differentiate between when they're hungry, when they're tired? Do they have that internal locus of control, or do they not? We'll talk a lot about what's easy related to toileting, what is more challenging. Like Dr. Amy said, we'll work with some kids that have a complex history with toileting. So they might have some phobias or fears related to toileting. So we'll ask a little bit more about that as well. And then diving into the strength assessment, we'll look at the lower extremities and just determine if the strength is within normal limits or if there is a muscle group related to the pelvic floor that might be just a little bit weaker. And then we'll look at endurance. So during our therapy sessions and the clinic visit, kids are up and they're moving and they're doing crab walks and bear crawls, and they're pretty active. So we're looking to see how do they coordinate their body? Do they have body awareness? Is one side of their body maybe a little bit stronger than the other? And what asymmetries might exist? Like Dr. Amy said, we'll talk about eating. So we have had many kids come into clinic where they'll start out we had a patient recently that said they only drink Mountain Dew and water and they'll only eat orange chips. So that kind of grounded us to say, hey, we need to start with the picky eating portion first in order to build off of that and then address the pelvic floor dysfunction that might be existing. The other piece is biofeedback training, which we'll dive into in the next few slides. Some kids that maybe have a slower moving gut can benefit from abdominal e-stim. So there's some really great research that suggests that it is able to help with the peristalsis, so the squeezing motion that the intestines help provide. And then daily routine modifications that Carrie talked about and Dr. Amy talked about previously. So the biofeedback assessment, again, this is obviously an intimate thing, learning about the strength and the coordination of the pelvic floor. So usually we'll talk with families, we'll kind of explain the biofeedback assessment, and then we'll have kids do the assessment first on their arm. So these electrodes will get placed on the child's bottom. They don't have any type of electrical impulse. They just read muscle activity. So kids will first come and we'll put the electrodes on their arm and we'll say, we want you to squeeze your muscles and then we want you to relax your muscles. So like a lot of talks discussed this morning, having a bowel movement takes so many different motor movements in relaxation aspects. So we're wanting to see, can the child relax? Can the child contract their muscles? And then can they coordinate their muscles? Can they transition from squeezing to relaxing and squeezing and relaxing? So trying to determine what might be easier or more challenging for the child. They'll do this activity in lots of different positions. So we'll first have kids lay on their belly and tell them to squeeze their muscles and relax their muscles. And then as they master that, we'll put them into different gravity assisted and eliminated positions. So standing, sitting, kneeling, just to see what their muscles do in lots of different planes. So this is a video. I'll kind of talk as you're watching the video. This is an 8-year-old patient where his strength looked really good. His endurance was okay, but initially the hardest thing for him was going between squeezing his muscles and relaxing his muscles. So a lot of the therapy sessions that we did focused on training that. So the computer screen is the biofeedback device. And if you can see, there's a green line. That's kind of the initiation of the biofeedback. So I'll just start this video for you guys. There we go. So I am just cueing him, letting him know we're going to do 10 seconds of squeezing and 10 seconds of relaxing. So I'm going to start it then. So I'm asking him to squeeze his muscles, and he's getting that visual feedback. So he's able to watch the screen go up when he squeezes appropriately. And then once the 10 seconds is done, I cue him to relax, and he's able to see that difference. So we have different games that are available too. So there's a dolphin game where the child squeezes their muscles and the dolphin jumps in the air and they relax and it jumps back in the water. One with a flower. So wanting it to be interactive. And I think for a lot of the kids that we see, they've had a really long history of difficulty with toileting. So they just lack body awareness. So this is kind of the tool we use to teach them what their muscles need to do and how they can be successful with that. So again, the work phase, it's going up. The relaxation phase, it goes down. Later in the video, this specific patient, he also had a hard time knowing how to apply this to his daily routine. So we talked a lot about when you are out and you're playing with your siblings and you feel like maybe you have the urge to have a bowel movement, what you need to do is you need to contract your muscles, run to the bathroom, get to the bathroom, sit on the toilet, kind of start that initial push that Dr. Yeager talked about, and then relax your muscles to successfully void. So we did a lot of simulated practice of, okay, let's practice squeezing for 30, 40 seconds. We'll pretend to run to the bathroom. You'll get to the bathroom and you'll relax. So no child or teenager presents exactly the same. So I think this is a great tool in conjunction with the arm test that Dr. Yeager talked about to really see what aspect of toileting, if it's related to the pelvic floor, is more challenging. So a lot of kids have a hard time relaxing. So let's teach them how to relax their muscles. A lot of kids have a hard time contracting. So let's teach them how to contract their muscles. So he did a really great job and was pretty motivated by it too. And then we'll be all done with the stickers. And again, this just is a kind of a picture of what we saw on the screen. The first one, the blue one, is just looking at resting tone. So we'll usually take a resting tone measurement on the first assessment just to see when the child sits on the toilet or a simulated toilet, what does their resting tone do? Is it low? Is it high? How can we train that? And then also looking at, then I ask you to squeeze and relax. What does that look like? Are you able to do that, or is that a little bit more challenging? And I know we have some kids in the audience. If anybody wants to volunteer, no pressure. I will just talk through some of the exercises and different things that we do too. Otherwise, the pictures will be good too. Do you want to come and do some exercises? I'll do them with you. No, that's okay. No big deal. Oh, perfect. Woohoo. Awesome. Okay, so a lot of what we'll do in therapy, we'll do some exercises. My favorite is the frog. So that's what this little girl's doing. So I want to see, can you try and squat down and get into this frog position? Oh my gosh, that's perfect. Okay, and can you hold it for 10 seconds? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Awesome. Was that one easy or hard? Easy. Okay, high five. Perfect. Thanks for volunteering. You can go back up by your seat. A big aspect of therapy sessions will be the biofeedback training, but we'll also do a lot of endurance and strength training as well. The core muscles and pelvic floor muscles work together. So we'll work on strengthening the core, work on strengthening the pelvic floor. with sit-ups, yoga poses, resistance training, and really trying to treat each child as individuals. So looking at what is more challenging for them, and then how can we make a home program specifically targeted to that. And that is all that we have. We want to open up to any questions or anything that needed clarification. Yes.
How successful is it for children who have those varying cognitive abilities or cognitive delay?
Great question. I think that's something that we assess a lot in clinic. So the big aspect for biofeedback needing to have a fair understanding of cause and effect. So being able to know, when you hit the toy spins, when you squeeze your muscles, the screen goes up. So I would say there has to be some aspect of cause and effect established. However, we see a lot of kids that have varying levels of cognitive abilities. And some kids, maybe biofeedback is not the best approach, but there's still some strengthening that we can do. And there's still, like Carrie and Dr. Amy talked about, routine modifications that can happen, medication modifications that can happen. So I do feel like we treat a variety of kids. So biofeedback might not be perfect for every child, but I think there's a lot that therapists can do to kind of supplement all the other medical goals.
And sometimes if we use, is this on? Sometimes if we use the biofeedback to give us information about how the child is able to relax. So in therapy, if we're using the biofeedback and we can get the kiddo in maybe like this is the dead bug position here. Does the child get into certain positions where they're able to relax their pelvic floor muscles naturally? Can that be part of the toileting routine at home? So if we're going to have the child sit after meals, maybe we have lunch, we go in the bathroom, we get our yoga mat out, we do the dead bug for 30 seconds, and then we sit on the toilet. So is there something we can still incorporate into the program, even though the child may not be able to actively squeeze and relax on command? Can we still come up with something that is beneficial for the kiddo? I also know that our psychologist works a lot with families of children that have some cognitive impairments to really put in a routine so that a child can learn that even though they can't appreciate that their body needs to pass a stool, does it become part of their daily routine? I eat, I sit, and then I can go and do my play activity. We do a lot of visual schedules so that if families or children can't understand that routine, they can see it. Oh, here's a picture of my plate. Here's a picture of the toilet, and then here's a picture of my toys. So I know I eat, I sit, and then I can go play. So as we put structure and routine into place, those kids, even with cognitive impairments, can learn a routine, and hopefully we can build on that as they're having some success.
Is this something that is generally taught to all occupational therapists, physical therapists, or do you need special training for that? Because I know in Toronto, we've had a lot of trouble kind of getting a program going because it just doesn't seem to be the expertise.
Absolutely. As an occupational therapist and my PT colleagues, there's an overview in grad school of these types of interventions. So it is a lot of extra education. So lots of like continuing education classes specific to this. There are some certifications that you can get after X amount of hours. So I think that not any physical therapist or occupational therapist would feel comfortable treating this population. But a lot of like women's health and men's health, like adult facilities, will also sometimes treat pediatric patients. So if you are in more of a rural area that might not have the same resources as a more urban area, even just a basic women's health or men's health place probably does have some experience treating pediatrics. So that could be a good place to start.
So I have two questions. In terms of children's diets, knowing that there can be picky, has there been any results in supplements that have been helpful in nutrition replacement, anything like that that have worked for children?
And I would defer back to the GI team on that. So we don't necessarily come up with specific dietary plans for those kids. If the kid comes to me on a constipating diet or a diet that is limited in sugar or something like that, we will put a routine or a plan into place to help that child meet those goals. But I don't know of any research particularly showing the need for supplements or for kids. Okay. I know I get a lot of questions about probiotics. I have a lot of families who are asking me about the benefit of probiotics. And I don't know the downside of using probiotics, but I don't know that I can hang my hat that that's going to be the big fix for some of these kids.
Yeah, I don't think there's great evidence that they're necessarily helpful. But for many, there's probably not a downside, like you said,
Yeah.
and they have that potential for some to be helpful. But no, I don't think there's a specific supplement that's needed. And then if you're just not able to get enough nutrition in, I think there's so many different like formulas and things out there that we really rely on our dietitians a lot to help kind of with what's in there to break down, you know, the amount of fiber, the amount of protein, that sort of thing for a given patient's need, I think.
And my second question would be these exercises, a lot of them seem to be easily done at home. How often do you recommend the children doing them?
So great question. I feel like I typically will say 5 days a week, like 5 to 7. Obviously 7 is ideal, but that is not the world we live in because there's always going to be a soccer game or a swim meet. So I would say at least 5 times per week. So sit-ups is a really great one to incorporate. You can even just do like a search on the internet for pelvic floor yoga and come up with some to incorporate into the daily routine as well. I think for yoga poses, depending on the child's endurance, having them hold for 30 to 60 seconds to work on that endurance piece would be great. But those are definitely small things that you can just incorporate into your daily routine.
For the biofeedback piece, usually the kids are coming to us once a week for the biofeedback. And then as they're showing some success, we put in a home exercise program and the frequency of in or outpatient therapy will back off, but we'll still stay in touch with families to make sure that the home program piece is still going okay.
Can you talk a little bit about mental health support in your program and how it ties in with your overall treatment plan? Because a lot of us have talked about kind of the psychosocial stressors associated with this diagnosis, but not much about the treatment.
Yeah, that's a great question. I wish Dr. Claire was here to, I have to speak for her today, but our psychologist, works a lot with help. It depends on the age of the child. It depends on where they are developmentally. So if they are an older school child and are willing to talk about the stressors they have around toileting, sometimes we can help use that as a motivator to help them comply with the program that we're putting into place, because ultimately they want to be the kid at school who's not having accidents, and they want to be the kid on the baseball field that's not having accidents. So helping the child understand that all of the things we're asking them to do, those 5 pillars of our program, are all to help lead them down the road to continence, which is ultimately what they want and is what's going to make them feel better about themselves. I will say in our functional constipation population of kids, when we can make goals, when we can meet goals in those 5 pillars and we can make progress towards continence, I do get a lot of reports from family that mood improves, behavior improves, lashing out gets better, the child feels better, they're more active, they want to go out and be with their friends more. So sometimes mood can change just because their bodies are functioning better and they have a little bit better sense of ownership and control of their body, and hopefully are having some success. I think if we really run into a lot of trouble with anxiety, depression, some of those other things, our psychologists will talk with the families about getting more specific services in place that can really focus on those pieces. Sometimes we need to refer to a psychiatrist as well. Maybe it's so invasive that the child might need to try some medications too.